Monitoring pupillary size and the reaction to light is an integral part of neurological assessment and of neurological monitoring. In this presentation, we discuss the pupillary light reflex. We discuss the types and significance of pupillary abnormalities. Pupillary reaction or the pupillary reflex involves pupillary constriction in response to light when a light is flashing in the eye, or to accommodation when you focus on a near object after looking at a distant object. Any reflex has got an afferent arm and an efferent arm. The afferent limb of the pupillary reflex is the visual pathway. You have the eyes, retinae, optic nerves, the optic hairs, the optic tract, and before it reaches the thalamus, there are fibers which go to the pretectal region. This is the afferent arm. The efferent arm involves the parasympathetic supply of the pupil. Parasympathetics are the constrictors of the pupil. The fibers originate from the Edinger-Westphal nerve and they travel along the third nerve. When there are constrictors of the pupil, they also have to be dilators of the pupil. The sympathetics are the dilators of the pupil. The sympathetic supply arises from the cervical spinal cord, and the sympathetic fibrils travel along the carotid and the ophthalmic arteries. Normal pupillary size depends upon the balance between sympathetic and parasympathetic pupillary innervation. We have already seen that sympathetics dilate the pupil and parasympathetics constrict the pupil. So, in anxiety states, for example, both pupils might be larger. When a person is sleeping, the pupils tend to be smaller, more constricted. What is more significant is an asymmetry in the pupillary size, especially if it is of recent origin. Asymmetry can occur because of a defect in the afferent limb of the pupillary light reflex. What is the afferent limb? The visual pathway. So optic nerve injuries, especially in an injury setting, are a common cause of what we call an afferent pupillary defect, which results in a larger pupil on one side. The efferent pathway of the pupillary constrictor light reflex is the parasympathetic supply. The parasympathetic paralysis can occur because of various reasons. The third nerve carries the parasympathetic fibers from the Edinger-Westphal nucleus on its dorsolateral surface. Uncal herniation, because of a rise in pressure on one side, can result in pressure on the third nerve and a pupillary dilatation because of parasympathetic paralysis. A peak-bone aneurysm which touches the third nerve might also produce a third nerve palsy. Some injuries, especially inertial injuries, might be involved with a small injury to the third nerve in the prepontine cistern. You might find a dot of blood along the course of the third nerve and an ipsilaterally dilated pupil. Sometimes you can have pupillary asymmetry without having any involvement of the third nerve because of a nuclear cause. These are sometimes difficult to explain. A patient, for example, without any increase in intracranial pressure, might suddenly show a pupillary dilatation. This might cause panic, and a CT will often show that there is nothing of significance which is present on the third nerve. These are probably because of electrophysiologic seizure-like phenomena which have caused a temporary nuclear paresis. What about sympathetic paresis? The sympathetics are dilators in the pupil. A paresis would produce a constriction. Horner syndrome is a classical example of a sympathetic paresis. Carotid surgery may be followed by a smaller pupil on the same side. Another cause of an ipsilateral or a unilateral dilated pupil is a direct trauma to the eye, which results in a condition called traumatic iridoplegia. I have seen this in patients with shuttlecock injuries to the eye. A unilateral dilated pupil in a person who is otherwise neurologically intact and alert after a shuttlecock has hit his eye is probably suffering from traumatic iridoplegia. So how do we check the pupillary light reflex? If you take a torchlight and shine the light in one eye, light goes in through the optic nerve, that is the afferent pathway, and the efferent limb comes through the third nerve. The parasympathetic outflow from the Edinger-Westphal nucleus comes along the third nerve to constrict the pupil. Both the afferent and the efferent arm are intact. There is pupillary constriction. If you shine a light in the opposite eye, light goes through the optic nerve. It again goes to the pretectural region, stimulates the Edinger-Westphal, and both pupils are constricting. So even if a light is shown in the left eye, the right eye pupil will constrict. This is called a consensual light reflex, as opposed to the direct light reflex, where a light shining in the same eye produces pupillary constriction in the same eye. There are two terms. One is an afferent pupillary defect. This implies that the visual pathway is impaired. The optic nerve is probably not conducting. In a conscious patient, you can always confirm an afferent pupillary defect because he will have relative blindness or at least decreased vision in that eye. In an unconscious patient, you'll have to totally depend on the reflexes. A pupil that remains dilated does not constrict with either direct light or a light shown in the opposite eye, has probably got an efferent pupillary defect that is commonly because of a third nerve involvement. In an unconscious patient, how would you assess the pupil? Like we already said, a direct light reflex positivity implies that both the afferent and efferent arms are working. The optic nerve is conducting, the third nerve is bringing intact parasympathetic fibers back to the pupil. The direct reflex is positive, but the consensual reflex is negative. It is light shown in the opposite eye, does not produce pupillary constriction in the same eye. It only implies that the opposite side optic nerve is not conducting. There is an afferent pupillary defect on the opposite side. If the direct pupillary reflex is absent, but the consensual reflex is present, in that case, there is an afferent pupillary defect on the same side. And if the direct and the consensual reflexes are both absent, there is a pupil remains dilated. There is a same-sided third nerve involvement, or rarely nuclear involvement. There is an efferent limb involvement. There are some abnormal but symmetrical pupils. The cadaveric pupil is classically mid-dilated. However, a patient who is going into brain death might initially have wide dilatation of the pupil before the pupillary size comes back to the cadaveric mid-dilated position. This is because the hypothalamic midbrain outflow ceases before the sympathetic outflow, which is from the cervical cord, stops. Sympathetic pupils are widely dilated. A patient who is on sedation and paralysis, if you stop his sedation, he might wake up and find himself paralyzed, and the pupil might become widely dilated because of acute anxiety. Parasympathetic pupils are constricted. Pharmacological pupils are usually constricted pupils. Some midbrain pathologies, or even a midbrain descent or a small blood clot along the area of the midbrain, might result in small pupils.